That's an interesting question, because perampanel and many of the other older medications, because of change in the FDA regulations, are now approved for epilepsy. So there's this whole issue of indications for second-line treatment, first-line treatment, adjunctive treatment, new onset epilepsy is gone. So a lot of these medications are now being viewed as, if a patient has epilepsy and they're above 4 years of age, in general, because that's the way the newer shift has occurred, those patients are eligible to use the medication for the kind of epilepsy that medication is approved for. So a lot of medications, such as lacosamide, such as perampanel, and some of the other medications, are now approved for monotherapy for epilepsy at 4 years and above. So now, as a pediatric epileptologist and neurologist, when we see patients with new onset epilepsy, we have a much larger armamentarium of medications to choose from, because now most of them are approved for monotherapy treatment in epilepsy. So you'd ask me the question about perampanel, and as far as perampanel is concerned, it is approved now down to 4 years of age for partial onset seizures and for seizures that become secondarily generalized. It does have very robust efficacy for patients who have either secondarily generalized seizures or primary generalized seizures. So you have a large number of choices for partial onset seizures, but specifically as it relates to generalized epilepsy and the effectiveness of perampanel for generalized epilepsy, regardless of whether it's primary or secondary generalized epilepsy, there are fewer drugs to choose from. And because perampanel has demonstrated effectiveness in that group of patients, it becomes a drug that we consider much, much earlier, either as monotherapy or adjunctive therapy for generalized seizures. I've been treating epilepsy for the last 35 years and have seen tremendous changes in the antiepileptic drug choices, the tolerability issues, the issues that relate to compliance, half-life, and newer drug development that allows once-a-day dosing. But as far as managing breakthroughs, I think counseling, first of all, is a major issue. Speaking to families and telling them, look, I don't want you to have tolerability issues, so rather than not taking your medication, let me know immediately so we can try and figure out a way around it. And talking to them about the risk of breakthrough seizures with noncompliance. Also talking to them about SUDEP, which is sudden unexplained death in epileptic patients, because although it does create fear, it also creates a reality basis of why it's so important to take your medication. So I think really good communication, looking at all the different options, and providing an open forum for communication for the patients, I think makes it much more likely that you'll get compliance and decrease the frequency of breakthrough seizures.
Well, we've had drugs for seizures for 150 years, but starting in the early 1990s, we began to get a number of new drugs that are not always more effective, but they have fewer side effects and they're easier to use. So every time a new drug comes along, we find some people for whom it's just the thing. It's just exactly what they need. And it's hard to predict that in advance. So treating epilepsy is still a trial and error process to some extent. We try to pick out a drug that's appropriate for the patient's seizure type and be sure they can tolerate it, because these are drugs that they have to take for many, many years. So both these drugs have proved to be effective and useful.
The impact is significant for patients for epilepsy. One, from a psychological standpoint. So a lot of patients whose seizures have been well controlled, and they don't have to think about the fact of when am I going to have my next seizure, and then all of a sudden they have a breakthrough seizure, and it kind of resets the whole picture for them. If you talk to them, they will say, after you've had a seizure and you've been to the emergency room, you think about when you're going to have your other one. And the further away you get from your last breakthrough seizure, you think about it less and less and less. And the impact that has on your daily life is significant. Also, there are morbidities relating to breakthrough seizures, injuries, visits to the emergency room. So it really is a major negative impact on daily life, and then for the way those patients function in a period of time thereafterwards. Now, if you had to think of it, depending on what work you're involved in, those people who are involved in manual labor or truck drivers, the impact of having a seizure is significant. Even if it's not while you're driving the truck. I mean, while you're driving the truck is significant, but if you're not driving the truck, it creates, you can't drive afterwards. It affects your ability to earn money. Now, if you're involved in a white-collar job, it still has an effect because it affects the people around you. It affects the way they view you. But at least you can go back to work and you're not going to do anybody any harm. But if you think of the labor force and the impact of having a seizure on the kind of work you do, it's a major impact.